Good morning. This morning we welcome Congressman or retired Congressman Dr. Michael Burgess, who was a physician for 25 years and was in Congress for 22 years. And welcome, Congressman. Appreciate you being here. How is retirement treating you?
Yeah, well, we don't call it retirement. I tend to think of myself as long-term, chronically unemployed now. First time since 1972. It's obviously been an adjustment since the first of the year when for the first time in 22 years, I didn't go for the swearing in of new congressmen, and but on the other hand, it was time. No regrets. Just so your audience knows, I was not defeated. I was not indicted.
Mm-hmm. Yeah.
I left on my own free will, standing with my head held high.
No drama.
Yeah, no drama.
Right.
But it's the pace of life when you're a member of Congress is so intense.
Sure.
And it does take probably, I don't know, 2, 3, 4 months to sort of decaffeinate from that hectic pace that you had previously. Now, I know, people look at the news right now and they say, "Oh, the government shut down. No one's up there. No one's working, so it doesn't look too darn hectic." But even in those times, it is, of course, things are extremely hectic. There are continuous conference calls, meetings with constituents, meetings with businesses and industries in your district because they're concerned about the activities or the actions of Congress, regular constituents who are concerned about whether or not they're going to get a paycheck or their child who's in the military is going to get a paycheck. All of these things you've got to be dealing with those continuously, even in a situation like we're in right now.
Yeah, and I'm sure you discussed this with your family, and it was time. What was that compelling reason after 22 years in Congress that, other than it was just is overwhelming sometimes, but what was kind of that one thing that said it's time to retire? Just curious.
My wife. Texas has a really early primary. It's the first Tuesday in March, and so as a consequence, 90 days before is the closure of the filing period. So we have a very early filing period. It's basically early November of the year of the off year when we run every 2 years, and the even number years are political years. The other years are off years. But even in the off year, you're continuously planning and working towards what that reelection cycle will look like. And I'd been doing that, and the truth be told, from a fundraising standpoint, I was in pretty good shape. From there wasn't any opponent of any magnitude on the horizon. There were a lot of reasons why things were kind of lined up for it'll be pretty smooth sailing to win another term in Congress. But as I always told people who would scream at me about term limits from the back of my town halls, that it's not a decision it's not a foregone conclusion every year. You sit down and talk with your family and make an assessment and the pros and cons. The pros looked pretty positive that it's not going to be hard to win another term. At the same time, I had been there at the conclusion of the current term, I would have been there for 22 years, which was much longer than I had ever intended to serve when I first started. And I had a discussion with my wife, and she said, how you come home sometimes and you say, that Joe Biden, he's just too old, and he shouldn't be doing this anymore. And you wish someone in his family, maybe Jill or Hunter, would sit down with him and say, you don't have to do this anymore. And she said, well, I'm telling you, you don't have to do this anymore. And it was sort of like a light went off. Okay. I don't have to do this anymore. Maybe it is time. And I'd served for 22 years. Obviously, there's always a lot of anxiety about are members of Congress getting too old? When I started, I was 52. I was sort of the average age of a member of Congress, particularly in the member of the Texas delegation. But as things had gone on, I was one of the older outliers. I was a septuagenarian, for crying out loud. I didn't even know that word existed until I turned 70. So it was, and you want to let a new generation come on board. It's
Sure.
If everyone stays until the final bell, which we saw the Democrats do this last cycle, and 4 of them died after they were sworn in before they could ever vote on anything of substance. So they've spent a good part of this year trying to run special elections and elect people to fill those slots of people who have passed away in Congress. So that's not a good situation either. And and 2 of those were committee chairs. So I mean, it leaves a big or in the case of the Democrats are in the minority now, so they were ranking members of their committees of jurisdiction. Raul Grijalva, who was recently replaced by his own daughter, he's significant to me because when I first was elected and first flew up to Washington for that orientation, we didn't know each other.
And what year was this?
This would have been 2002, in November 2002, right after the general election. You go up for a 2-week orientation period. We were on the same plane. We didn't know each other, and we got off the plane, and you are actually met by the United States Marines who escort you to baggage claim.
As a newly elected member of Congress.
It never happened after that. But yes, as a newly elected member, and it was Raul Grijalva and myself who were escorted to baggage by the Marines at that point. And we sort of formed a bond at that. Well, although we disagreed about everything, we agreed about nothing. But we always had that, the spark of recognition that, hey, you were one of the first people I encountered when I ascended to this office. But it was time. And there's good young people that have come on board since I left. So I've got every confidence that the next generation will serve well. It takes a while to get your feet under you once you get there. It takes a while to learn what the heck you're supposed to be doing. I mean, there aren't really books on what does a congressman do. Well, there's some books, but they're not always accurate. So there's a pretty steep learning curve when you first get there. And so you want that continuous gradual turnover of new members, particularly within your state delegation. When you're in a state as big as Texas with a delegation, we have 38 members of Congress and 2 senators. So that's a pretty big crew that the state of Texas has. We're second only to California in terms of total members of the House.
Do you get assigned like a mentor when you go to Congress as a freshman?
Yes, and then you pick one from everyone else who's left.
Oh, gotcha. Okay. So you had a thriving practice in North Texas for 25 years.
Yeah, the best.
At what point did you decide, and why did you decide you wanted to run for Congress? I get it. I mean, so many folks think about that, but you actually did it. There had to be something that spurred you on, and not only just to go and run, but then to stay there as long as you did.
Well, I get asked a lot of times, what was your secret for winning your first race for Congress? And I tell you, my secret is you don't want to emulate what I did. I made the decision relatively suddenly, and honestly, it was in reaction to the attacks on America on 9/11 in 2001. And I'm just a regular guy doing my job. I'm scrubbed in the operating room that morning.
So this is on 9/11?
Yeah. Started a case with I was doing with the urologist. He knew it was going to be a long case. These were complicated cases that we did together. And, I didn't want to dispel anyone's notions that doctors are always serious. We typically listen to rock and roll, but on the radio. So we listened to one of the classic rock stations in surgery, typically. But it got interrupted by been a terrible accident and a plane has flown into a building in New York City. That's too bad. I'm a private pilot like you, and so you think, some poor devil got disoriented and maybe the weather played a role. So this is a terrible tragedy. And then before you know it, there's notice of a second plane has hit the World Trade Center, and that doesn't sound like a series of accidents. That sounds like an intentional act, and something of that order of magnitude is likely going to be.
So you were listening to this while you were in the operating room?
That's correct.
Oh, my goodness.
Yeah, the rock and roll station switched over to, I think it was ABC News coverage, sort of along the way that morning. They picked up the national feed, and so we were just listening to it continuously, and then the towers fell, and one tower fell, the other tower fell, and but we're still having, we got to take care of our patient. We had a big operation that was going to take a lot of time.
Yeah, I was just going to ask, what operation were you performing and the patient turned out okay?
Yes, everything worked out extremely well.
Okay, good.
My son was in the Air Force at the time, and so I was naturally concerned about what is happening in his world right now. I'd go out to visit him at his base in Clovis, New Mexico, and they'd have big posters on the wall, we're the fighting fireballs, we're America's go-to wing. And I thought, oh my gosh, they're America's go-to wing. They may already be in the air going somewhere. We didn't even know who had attacked us at that point. So a lot of concerns on my mind for the country, for my family.
Of course.
But obviously from a patient. And we took our time. We did the case correctly, and everything finished up okay. We got the patient to the recovery room, and of course, then I hike off to the doctor's lounge, not to so much to dictate the operative note, but see what the heck is going on the television. I missed most of the dramatic footage that people saw that morning. People apparently becoming disoriented or dispirited and jumping out the windows of the tall building.
Yeah, it was awful.
And they quickly scrubbed that. It did not show that anymore. So I don't know that I've ever actually seen what most people saw as that morning evolved. But there was still plenty of drama and the smoke and the dust from the buildings collapsing. So, watching all that morning and then finally getting a hold of my son, and no, he wasn't on a C-130 headed overseas somewhere. They were, trying to, in information gathering mode and trying to figure out what the next steps were. And again, we didn't even know who had attacked us at the point. I mean, who would ever most people hadn't even heard of Afghanistan except for the Olympics being canceled in 1980 because the Russians had invaded them.
Sure.
But it was after that, and I didn't know that it would affect me. If someone had posed a hypothetical to me, say, hey, this is going to happen, and then what would you think after? Well, I'd be sad. I'd be mad that people had attacked my country. But it wouldn't be disruptive in my life. But it turns out it was. And to tell you the truth, I had a good friend who was a general surgeon, and he was up in New York that morning. He had gone to New York to do the review course for you've got to renew your boards every 5 or 10 years when you're a board certified practicing physician. So he was up there to renew his surgery boards. And they were in this big room in a, typical banquet room or conference room at a big hotel in New York. Someone came in the room and said, oh, there's been a terrible accident downtown, and the course is canceled, and we'll get back to you with other information. And then it came down to the lobby, and there's Mayor Giuliani on the television screen saying we need anyone with any medical expertise to come to the downtown area because we've had this terrible accident. There's a lot of injured people, and we need medical help. So this group of surgeons who was there, they presented to them and said, look, we need help. We're going to bring a bus to the front of the hotel, and we'd like for you to come down to the pier area with us. And several days later, I'm talking to Jim about this in the doctor's lounge. It was probably Friday after this all happened. He couldn't get home for several days. And then when he finally did get home, he had a lot of stuff he had to catch up from. And so he and I were both doing a late case on a Friday, and we're kind of between cases on a Friday night. And I came into the doctor's lounge and had a discussion with him. And, what was it like to be there? He described how the whole scenario unfolded that morning. And as I'm driving home, I'm thinking, man, that took a lot of courage to get on that bus and go downtown because he didn't know what he was going to find.
Of course.
He didn't know if he was going to be in danger. I don't know if I would have had the courage to respond like that. And so I beat myself up on the way home and said, no, doggone it, if that opportunity ever presents itself, if that door ever opens, you don't hesitate, you walk through it. And you do it with conviction and, clear-eyed about what you're trying to do. As things went on through the rest of September and into October, I'm more and more despondent about, am I doing what I'm supposed to be doing with my life? And
like a calling almost.
Yeah, almost a calling.
So I remember how much it affected me. I don't have nearly the story you did. I was just getting ready for work, putting my shoes on when it came on the television, the first tower, and then I watched live the second tower. I couldn't go to work. I just was stuck watching that, but it affected me deeply as well. But this is what you're saying is really what said, I've got to find a bigger meaning or a bigger purpose, so to speak.
I don't know that I distilled it down to those as precisely as you just did, but I knew that the country needed help, and what was I doing to help my country? I couldn't identify anything that was useful, and that if that opportunity arose, that I wouldn't hesitate, I would take it. What I didn't know is that my member of Congress, who'd been there for a long time, decided in early December that year, again, we've got an early filing period, we've got an early we were several weeks into the filing period, and he announced that he wasn't going to run for Congress again. And it's like, oh my gosh, well, that's not the door. No, that is not the opportunity that I was thinking about.
Sure.
But I studied on it and prayed on it for several days, and I didn't really know anyone in the government. There wasn't really anyone I could call up and talk to. Hey, do you think this is a good idea? But I did call a few people, and immediately some of the people I talked to said, "Oh no, don't do that. Doctors are always trying to run for office, and they always get everyone excited, and they're not successful. They cost a lot of money, and it's just not a good idea." But then one of my local elected officials said, "Oh my gosh, you'd be perfect. You'd be the perfect person to you've lived in the area so long, you know so many people, your kids have gone to public schools in the area. You'd be the perfect person to run as a representative of the area." And it sort of stuck with me. Then that person I'd called at Texas Medical Association who had discouraged me suddenly had a change of heart, probably because he talked to the same elected official and said, we'll help you. We'll identify a consultant, and the consultant identified that he could charge me a lot of money.
Of course. It's not cheap to run for Congress, is it? What does it cost today for somebody to run for Congress? Again,
I'm not a good one to answer that question because I probably spent $100,000 on that first race, which is, I was criticized mightily along the way that I needed to put, if I wasn't willing to put $250,000 of my own money into it, I wasn't serious. But at the same time, I thought it's either something that's going to be supported by people that I know and neighbors and the grassroots, or it's not. And if it's not, then I shouldn't be wasting everyone's time. I spent 25 years and, talked to patients one-on-one, interview patients, get a medical history, felt pretty comfortable talking to a patient in the exam room or the treatment room, but I was no way prepared to talk in front of a large group. And the very first forum that we held there in Highland Village at the old Doubletree Ranch. And
there were in Denton?
In Highland Village in Denton County.
Sure. Which is North Texas. Yep.
It's just the old joke. If there had been a back door to the Alamo, maybe so many people wouldn't have been there. If there had been a back door in that forum, maybe I would have, because it was daunting to get there and give my spiel in front of a room full of people. But I got through it, and I got better as I went along. And what I discounted and I hadn't paid probably close enough attention to is people look up to doctors, and so you're held in pretty high regard. People stipulate that you know what you're talking about, and they generally are likely to listen to what you have to say. And I'll tell you, the person who actually pointed that out to me was Ross Perot, not me individually, but at a meeting of the Texas Medical Association a couple of years before. He stood up in front of that group and he said, you doctors don't realize the power you hold in your hand. He said, I'm Ross Perot. If I'm sitting up in my office and my secretary brings in a stack of mail and there's a letter from my doctor, I'm going to open it first and read it myself. And I thought, whoa, that, I hadn't really ever thought about that.
I think doctors lose that perspective, right? You're in it all the time. So, my wife, she's a doctor, and what she says carries a tremendous amount of weight. But when you're among doctors, it's just like regular talk. But people outside of it take that as like a gold standard, right?
Yeah, until you file for political office, then
Until you do, and then you're not the brightest person ever.
yeah, that's right.
Yeah,
That's correct.
Yeah,
And
exactly.
the letters to the editor start, and
Of course.
we didn't have Twitter back then, but you know the people who are opposed to you will be quite vocal about why you're not qualified to serve. And I'll just share this with you because I do get asked a lot of time by other doctors what makes a doctor think that they can do that kind of work. And I always point out that part of our job is to be good listeners, and if you're not a good listener, you're probably not a good doctor. And to be a good representative, you really need to be a good listener, and you need to be able to pour through volumes of information in a fairly short period of time, come to solid conclusions that are defensible conclusions. And that's, part of the life of Congress. What I found when I got there, I was assigned to the science committee. We were dealing with I don't remember nanometrology or some such thing on the science committee, and I'd be my staff would bring in a binder or two and say, "This is going to be the hearing tomorrow. You need to read through all this testimony ahead of time."
Sure,
and I was like, "Holy cow! Couldn't I got this last week?" They said, "No, we just got it." So.
And I think about what you just said. What resonates with me was the original intent of Congress, right? And to represent the people. And it's become a career, right? You can go to school and get a degree in this, and you spend your life in it. And that was never the intent when the Constitution was written and the Federalist Papers were written. Was we need somebody who is going to take the message or the voice or the heart or the soul of the people they're representing to Congress to affect whatever it is that needed to be affected. And I think about adequate representation, and the only way to do that, whether you're a doctor or not, right, is listen to people. And we've talked about this in the past, and it's an amazing perspective. So me not being in Congress, thinking this, looking from the outside in, what I think about is, well, you have a job to do. You also, every 2 years, have to reapply for your job. And it's not just you reapplying, it's you and everybody else who wants your job applying. And so you've got to fight that. You have a lot of competing voices that are happening. But at the end of the day, the objective here was that rather than every citizen going up to D.C. and having their voice heard, you basically combine that into a person who then represents those people. And I think anybody who has a heart for this country and the people that they represent, regardless of their background, can do a good job, right? Mm-hmm. I mean, I get when you get into Congress and you have the politics and you have committees and caucuses and all those types of things, and I get the professional side of it. But at the end of the day, when I think just as a private citizen myself, one of the things that most people feel that I think is just lack of a voice and lack of being heard. Right. And so from that perspective, taking the doctor piece out of it, how does anybody, right, get to their congressman or get their congressman to listen to where they feel like they were really heard and understood? I struggle with it because, as you know, with the students that I had, they feel very disenfranchised with the political process because, one, they say, well, nobody will listen to me, and two, it's not going to matter. That's half the reason why people don't vote these days, right? It isn't going to make a difference. And I know, having done this for a while, it absolutely does make a difference. It just takes eternity sometimes, right? I might pass away before some of the things I want to have happen. I get it. There's a reason for all of that. But if you had somebody come in your office and sit down and say, Dr. Burgess, this is really important to me, how do you bring that message to Congress? How do you let them know they were heard?
Well, let's break it down into a couple of the components. Just the communications job of a member of Congress, something I really hadn't contemplated before. Mm-hmm. And everyone obviously makes their own way in this. One of the things that I found extremely useful, my staff hated it when I did it, but I would do these large open town halls where people would come in and, literally stand in a microphone and read from a list of talking points that they downloaded from in their case, from a Democratic or progressive website that was critical of me. But it was just important to have those moments. No, they're not going to convince me. And I want to say that I modeled myself after Charlie Kirk because he obviously came, he was much younger than me.
Sure.
But it was that type of environment. Okay, I convened a crowd. I had a microphone. Tell me what you want me to know. And then I would reserve the right to respond after that, or perhaps the reason why I would not go in that direction, perhaps reasons why I had looked at that and decided on a different tack. But that is one way for people to at least get the impression that they've been heard, even though, well, the SOB didn't agree with me, but he had to listen to what I had to say.
Sure.
And, the reason my staff hated town halls is I would not control them. I did not ask for the questions to be written down and submitted ahead of time. I would not give a speech about how great I was and all the great things I'd done for the district in the last 6 weeks. But no, I'm here to hear from you. Democracy is a participatory sport, and I'm here to listen. I'm not here to talk to you. I'm here to listen to what you have to say. So again, we'd set up a microphone, people line up, and then at some point I would announce that we're going to have to, we were in an elementary school or a high school, the custodial staff is going to have to break things down after 9:30 tonight, so we're going to have to call an end to it, because they would just go on interminably if you didn't do that. There was a time right after the financial meltdown in 2008. I just really did not want the staff. If there was somebody who'd lined up in that line to address me, I did not want to cut it off before they had their chance to say what they wanted to say.
Sure.
Now, if someone is recycling themselves over and over again, oh, wait, you've had your turn. Let's give someone else. Yeah. But the staff was pretty good about managing that. But they hated the fact that I would just there wasn't a theme. It's not like we're going to have a town hall on whatever the issue is. We're just going to have an open chance, an open forum with for you to discuss your concerns with the congressman. But I found, from my perspective, that worked well for me to hear from people, and you can't always be taking polls and reacting to it. Sometimes you just need to hear from the folks. I will tell you something else that I did that I'm not sure other members of Congress do this. Every day I got a list of all the calls that came in to both the district office and the D.C. office, and would be able to see, what are the issues that are percolating to the top. And sometimes you would have an outside group that's, orchestrating some calls, and you'll see those come on the television. Call Representative so and so and tell him not to take my Medicare. That type of activity will happen, and you can kind of identify, well, we're getting a lot of calls on that, but it's being driven by some outside money for some reason. But just generally to get the tone of what your constituents are calling in and talking to you about. So what I would tell people is that, you don't think that your single voice is going to make much of a difference. So if you pick up the telephone or compose an email or even write a letter to the congressman, it's not going to make a difference. But in aggregate, it does. And I'll just give you one example of where it really profoundly affected how I ended up voting. Was right after the financial meltdown and right after Lehman Brothers collapsed in September of 2008. George Bush he wanted Congress to appropriate an ungodly amount of money to bail out the banks and
housing crisis. And,
yeah,
sure.
I didn't want any part of that. But my telephone calls were just like, I don't remember, 4,000, 7,000 to 1. I guess one banker called in and said, yes, give us the money. But people were just spontaneously driven to call in and say, do not do this. And it's important for me to have that kind of information, because when the vote's going on the floor of the House and you're getting calls from the president, the vice president, Karl Rove, I mean, you got to pass this. You may not like it, but you've got to pass it to save the country. No, that's not why this country was founded. That's not what this country is supposed to be doing. And I know a lot of people struggled with that particular issue, but for me to have that kind of support from back home that we do not want this. We've studied the situation. We know it's serious. But this is not the answer. It was important for me to know that going into that vote. And in fact, we had to vote on it twice because it was defeated one time in the House and the Senate resurrected it and sent it back to us. So I actually got to vote no twice and have to stand up to the administration 2 times.
So I do some advocacy work on behalf of patients, specifically, as you know, around prior authorization. And what we focus on is getting new therapies to market and getting physician societies involved and all of those typical types of things. Since you're the one who would be receiving this, let me ask you, so when we compose letters on behalf of doctors or patients because they don't know what to write, and they're nervous, like, oh, if I'm going to write my congressman, I don't know what to say. And so if we were to help them with a template to give them an idea, or physicians to give an idea, the reason I typically don't do that is because I don't want that template to fly around and then you get like 500 of the exact same thing. And I would imagine you would discount that after a while.
You might.
Yeah, okay. I hear you. We're on the same page with that. It really needs to be individual letters, emails, phone calls from not outside money, as you said. I imagine, as it would be for me, I appreciate that one-on-one relationship as opposed to I'm working with a PAC who's representing a bunch of people and they're trying to get advocacy. And I get it. That's important. That's the way you move things. But I imagine it really is that personal story from an individual. And then as you hear different individual stories, not the same story, that tends to resonate more, or no?
Yes. And what I encourage people to do, the congressional schedule is published. I mean, it's public information.
Mm-hmm.
So for example, that your member of Congress is going to be home for a week or 2 around Memorial Day, around 4th of July. The whole month of August. Varies in the fall of the year, whether it's an election year or not, but there are identifiable times when your member of Congress is going to be in the district office. I mean, it's great to get to do a fly-in and get a group of the pulmonologists or the family physicians come in to your office, and you've got 30 men and women in white coats saying, we want you to do this. That's powerful. But what's also powerful is to come into the district office with perhaps 1 or 2 physicians and 3 patients, and have the patients explain why this is important, why, you're hearing a lot about healthcare right now because the Democrats have decided that healthcare is their golden ticket to win the midterm election. Not sure they're on the right track, but nevertheless, you're going to hear a lot about it because that's the message they're pushing right now. But to get that on a one-on-one, with a doctor who knows the technical aspects of the issue, but then a couple of patients are probably just as important, if not more important, than the physician who's going to be there articulating what the problem is and how to fix it. And it's also, I would underscore that, how to fix it. Don't just come in with complaints. Come in with, this is what we've encountered. We think it's bad. This is one idea where you might fix it. Not the only idea, but it's one idea how you might fix it. So that is helpful also because, member of Congress is busy. And here's, give you a pro tip. The congressional staff is someone you want to get to know, particularly in healthcare, but also in energy or veterans issues or things that would affect the Committee on Judiciary. Get to know the staff that's the subject matter expert in that area, in your member of Congress or your senator's office. Don't forget, you have 2 senators, and you'll hear from them every 6 years or so. So they can be met with as well.
I think about it. It's almost like sales in a sense, right? If I have an issue that I want you to know about, well, what's the reason I want you to know about it, right? To affect some change or whatever that might be, or just to encourage you to continue to vote a particular way or whatever the case is. I think about that just in the private sector. where I am and spend every day. And as you're trying to sell whatever it is you're trying to sell, there's usually an executive admin that you need to get to know. And I think about it's kind of like reference selling of, that let's just say you have a chief of staff and you trust your chief of staff. And so if your chief of staff is bringing somebody to you, let's say me, you're going, okay, well, if James is bringing somebody, then he must have already vetted them and there's something here to it. So getting to know the staff. But the other thing I'd say too is there were many times when I was up in D.C. wanting to meet with members of Congress and the Senate that I actually never met with the congressman or the senator. I met with their staff. And actually that was more important to me when I met with like Jacqueline and we had a very specific conversation around healthcare. They were the experts. They could then distill my message down to 1 or 2 sentences to you of exactly what we're trying to accomplish, as opposed to me taking a half hour of your time. And so there were times I almost didn't want to meet with the congressman, right? Because you have 10,000 things going on and getting the mental time was really challenging. But your staff, that was their job and they would carry the water. And that meant so much to me once I figured that out. But you have to live that, right? Especially when at my age, I'm going in talking to a 24-year-old and going, are you sure you're going to communicate that to Dr. Burgess?
With a proper amount of passion.
Yeah, right, exactly.
Well, but you've hit on a great point, because you have groups that do fly-ins and they come to D.C. and they all come into your office. Okay, you've taken in the healthcare world, you've taken time out of your practice, away from your family, flown to Washington, gotten a hotel, listened to all these people talk at you, and then you're doing your Hill visits, and you just sit down to do your spiel about whatever it is you're there for, and then the buzzer goes off and, oh gosh, I got to go vote. And that's, you're left with the staff, and that's kind of a letdown. Well, wait a minute, we wanted to meet with the big dog. But the staff, most of the time, is going to be well-versed in your issue and maybe even a little more well-versed than the member. Mm-hmm. And so and establish that connection, get their email, because that's how staff work. They receive emails and answer emails. So get their email and communicate with them through email. Send a nice thank you for meeting with me. I'll never forget the kindness that you showed, blah, blah, blah. Mm-hmm. And that goes a long way towards building that relationship and establishing that relationship. I would see people who would do that very successfully. At the same time, I would see people who weren't so successful in how they handled things. It was more like, we represent 28,000 of your voters and blah, blah, blah. You'll do what we say or else. I carry some weight, but it's the old adage, more flies with honey than vinegar,
Of course. When I was teaching U.S. health policy, part of what we did was propose some legislation that would help improve healthcare, and the final paper was a letter to Congress and their Congress member, and maybe not theirs in particular. So let's just say it's a different committee and your local congressman's not on that committee. So it would be, to whomever. And part of it was identifying who would have the most interest in your topic, right? Whether it was your local or it was somebody else. But it was, what is the problem? What is the answer? What's the recommendation? I see too many times, you brought up Charlie Kirk, when somebody will come to that microphone and it's a complaint. And I get it. And when I hear somebody complaining, that means they feel like they haven't been heard, to me, that they just haven't been heard. And so rather than complaining back, right, it's, okay, well, think about why. Let's get past you felt like you haven't been heard. I get that. But complaining is not going to get you heard. What is it you're really trying to accomplish here? And what is your recommendation? And too many times it's, as my students would say, well, how come we just don't have healthcare like Sweden? We should just do that, or Canada. And I just shake my head. I'm like, okay, do you have any idea?
Oh my God. Yeah. I got to tell you a Sweden story.
Okay, go ahead.
Since you brought it up, I guess it was 10 years ago or so, I was on a congressional trip we went to several Scandinavian countries, it was August here, so it was, it was a nice trip, no question about it. But in Sweden, and I'll never forget this, there was you go to the ambassador's house, and of course there's
who doesn't?
Yeah, there's a naval liaison or a marine liaison there.
Sure.
The naval liaison, actually his wife,
Is it Sweden?
In Sweden, and of course it's a U.S. serviceman, and she's there with him, and she said, well, he hurt his shoulder playing racquetball and is going to need a rotator cuff repaired. But when we went to the doctor, they said, well, it'll be months before we can actually see you. And so they said, well, that's not good enough. So they got a plane I think down to Landstuhl in Germany to be seen by a U.S. doctor. And they said, well, you're right. You do need a rotator cuff repair, but you've kind of waited too long. Now you've got to wait until it's, I guess, settled down some before you can actually undergo the surgery. So he was actually harmed by that delay in his therapy. He couldn't use the shoulder for several months. But I'll never forget his observation was, well, they take 17 weeks of vacation a year in the public domain in the public service because they're only paid for the other 34 weeks a year. So why not? Why you're working if you're not getting paid? So that creates a mismatch between the supply and demand situation, and you're just access to a waiting list is not access to care. And that point was made by the Canadian Supreme Court when there was a Canadian representative who had breast cancer and was trying to get in and couldn't, and ended up having to come to Henry Ford Hospital in Detroit, which is what happens a lot of the times. And the Canadian Supreme Court ruled that access to a waiting list is not access to care. And they tried to change some aspect of the Canadian health system. But that is the problem, where you severely restrict, in order to be able to afford this national program, you restrict at the front end the stream of patients coming in. And there was another one who pointed out that wasn't a service member, but it was a member of the embassy staff, that fellow's mother had some heart trouble, and she went in, and yes, you're going to, she went in August, and you're going to need to see a specialist. But that specialist visit was scheduled for some time in October because everyone's on vacation, right? Because they're only paid for 34 months out of the year. And she died before she could get the specialist's visit. And that's the sort of story that you hear. I'm not saying you'd never hear that in this country, but you're less likely to encounter that in this country. Not that everything we do is good and perfect, but there is a downside. If you say, we want healthcare like Sweden's, well, what is Sweden giving up to get what you think you want? And one of the things they're giving up is access to their physician on a timely basis.
Yeah, and I think about one of the things with the students, I'd say, okay, so right now you give up 30 cents of every dollar to the federal government when you go out and get a job, right? These are college students, so they didn't quite appreciate that. and then they say, but if you were in Sweden, you're giving up almost 70 cents of every dollar to get that health care. Are you okay with that? And
you still got to wait till October.
And you still have to wait. So, it's just, it's such a complex system and such a complex issue. There's no one thing that's going to solve it. And I'll share a Sweden story too, and not to pick on Sweden. So I had PRK, which is like LASIK, a couple weeks before I got married. And then we did our honeymoon in Sweden. And so my wife and I were there, and I was taking steroid eye drops for the surgery. And I was adding too much steroid eye drops to my eyes, and I got a corneal tear while I was there. The pressures were so high, it was off the reader. Most pressures are, 10, 12. Mine was beyond 50. So very high pressure, and I was at extreme risk of losing my sight in my left eye. And so when this happened and my wife looked, and she's like, we've got to get you to the hospital now. We have to get these pressures down now. You could go blind if we don't. So we want to call an ambulance. There's no ambulance. So the hotel gets a cab for us, and we go to this one hospital. And we get there. I say, well, the eye hospital's closed. You'll have to come back tomorrow. And she's like, no, he'll lose his sight by tomorrow. And only because she's a doctor and she explained exactly what's going on, that they called an eye doctor to come in, and I was able to be treated that night. And they were great. Don't get me wrong, everything was good. I had to go back and forth about 4 or 5 times over that, so much so they actually gave me a Swedish healthcare card. I was going back and forth so much. But what I can tell you is if I didn't have a physician spouse advocate for me, I would be blind today because they were closed. It was just closed. And here I could go to any emergency care or just call an ambulance. I'd be in an ER in 10 minutes and they would have seen exactly what happened. But when she had first taken me to the regular hospital, they had said, he probably just has something in his eye. If it still hurts, come back tomorrow. I'm like, you didn't even look at it, right? And she, being a doctor, looked at it, goes, you got a tear. This is really bad. And I thank God for her. But if I would be blind in one eye if that were the case. So it's just sad from that perspective. But anyway, we're getting way off track on that. The point being is that...
So why didn't you, as a college professor, bring members of Congress into your class and have this sort of discussion so they could talk one-on-one with a member of Congress? I think that would have been very effective if you'd take someone like me and someone from the other side of the aisle and let's do the point counterpoint or the crossfire.
So folks can look up where I taught U.S. health policy. I won't bring that up here. But I invited Dr. Burgess a few years ago to talk about these types of topics, just how is healthcare managed from a congressional perspective in the United States, and how do we affect change rather than we just sit back and say, this sucks, that sucks. But how do we become part of the solution? And what is an educated solution? And let's not try to boil the ocean. Let's just pick something that we're passionate about and see if we can incrementally improve our system. And so I had invited Dr. Burgess to come speak with the students. And I had asked students to research some of the legislation that Dr. Burgess was involved with so that they could ask intelligent questions. Well, of course, Congressman Burgess is a conservative. They saw some of the other elements of where he stood, and they wrote to the dean and said, we will not participate in class and we shouldn't have him on campus and all of these types of things. So I had a long conversation with the dean and chair of the department and said, we're here to talk about health policy. He has been around 22 years in Congress. He was there when the Affordable Care Act was passed. He was there when Medicare Advantage was passed. Many of these policies, and just to hear from a congressman of what that entails was the objective. And so many students were so upset that I ended up having to cancel Dr. Burgess the night before. Because they said they were going to protest and all those. And I'm trying to convince the university that this wasn't a political conversation. This is a congressman who has been on the floor voting for health policy, a leader in Congress on health policy. You were the co-chair of the Doc Caucus, and anything healthcare related went through your caucus. You're the person to listen to. Regardless of anything else, you're the person. And they said, well, we should have somebody else. We should have a counterpoint to it. I said, this isn't a political conversation. This is purely a legislative conversation. And I finally, with the university, I said, I thought we were here to learn. I thought the objective of a college education is to be exposed to different thoughts, different ways of thinking, so we can expand our minds. We can expand the world that we live in. And they just weren't willing to support it. And at the end of the day, they said, well, Chris, if you want to go forward with it, it's your call, which we all know what that means, right? Which means it's your ass if anything goes south. And I'm like, no, forget it. And so I was really, really disappointed in that. We were there to just have a legislative discussion. I actually did invite the other side. Right. Not that there was a side to it. That's the problem. I didn't even want to get in that conversation. Right. I had invited Colin Allred multiple times. And it
was his district.
It's his district. Yeah, it was his district at the time. And he chose not to. And so you wanted to, again, just to have a legislative conversation. And ultimately that led to me resigning from being a professor, because we're here to grow our thinking, not just to reinforce what we have as a small view of the world sometimes. And that's the purpose of a university education, right? It's not a trade school. You're there to expand your thinking, and that's not what the university wanted to do at that time. Now, maybe that's different today, but it wasn't at that time, which is very unfortunate. Yeah. So that's what Congressman's referring to. It was disappointing because...
I had to needle you on that, Chris.
I know. It was very disappointing. And I appreciate having diverse discussions. So like I told you, we met with who's now running for Senate, Congressman Allred, right, to listen to his perspective, specifically around Medicaid expansion, why he thought that would be great for the state, and also because we're in Texas and we have a huge insured population, what that meant for illegal immigration and how much that's affecting and burdening the healthcare system. Forgetting all the other pieces to it, I don't want to get into that stuff, but there's just some pure math that has to be done, and how far are we willing to go? And it's tough because you have to make really hard financial decisions, and when you couple emotion with those financials, it becomes very tense topics to have those conversations.
Sure enough. And on the topic of Texas expanding Medicaid, I don't think it's going to happen. But the reason it didn't in 2010, when the Affordable Care Act first passed, was
so
Rick Perry looked at that and he said, this is a bait and switch, because, I mean, it was...
Well, let's just talk about, so just to kind of set the table as we kind of move into some of the policy discussions. So Obamacare, the Affordable Care Act 2010, that was passed. The way that it was conceived from the federal government at that time to get healthcare exchanges, they had to be run through state Medicaid programs, which gave each state the authority to decide if they were going to offer Obamacare in their state because it was going to be managed through Medicaid. Am I saying that correct?
Probably no. It was going to be managed through the marketplace. They call it, is what they call it. But the marketplace is separate from Medicaid. Medicaid.
So then explain Medicaid expansion as it relates to Affordable Care Act.
Well, in the Affordable Care Act, yes, they created this whole system of marketplaces. Remember, because it didn't work for the first several months after, in 2013, 2014, actually, when it came online, the website crashed. You couldn't actually buy what you thought you could buy on the website. So it was a big mess. But Medicaid was separate, and Medicaid was. Chris, we called it the Cornhusker kickback, the Louisiana Purchase. These were gifts that were given to Democratic senators to get them to vote for the passage of the Affordable Care Act when it was in the Senate in 2009 and 2010. Because Ben Nelson in Nebraska, Mary Landrieu in Louisiana did not want to vote for this because they thought this could cost me an election. They did vote for it, and it did cost them an election. But one of the things they tried to use to temper their political vulnerability was, yes, if the state is required to expand Medicaid to everyone, all childless adults, non-working folks of any age, that it would be Medicaid has a federal share and a state share. It's a shared responsibility.
Co-managed, for lack of a better term, yeah.
Well, it's all managed by the state, but part of the partial funding comes through the federal government.
Sure. And
that's referred to I forget what the acronym stands for. It's the FMAP. The FMAP in Texas is 57. That means 57 cents of every dollar that's spent in Medicaid actually comes from the federal government to the state. States that agreed to expand Medicaid to these new populations, actually that FMAP was going to be 100%. So that
meaning that the federal government would support 100% of your state Medicaid if you expanded the patient population that qualified for Medicaid.
Well, no, because the legacy populations that were supposed to be covered under Medicaid, blind, aged, feeble adults, poor pregnant women, those patients were still covered at a 57% FMAP.
Oh,
and the new populations were covered at 100%.
Oh,
it was a total.
So it wasn't 100% across the board.
No,
the traditional people by Medicaid was 57%, but the new population was going to be paid for 100%.
Yes, and that is what the Democrats have conflated that for years. They did that during the One Beautiful Bill debate this past summer, when the statement was made that we're going to, people are going to be losing their Medicaid. Actually, in Texas, we didn't expand Medicaid, so anybody here is going to lose it. The blind, aged, disabled, feeble adults, those people, the true safety net aspect of the program was going to continue because it wasn't changed. The Social Security Act was not rewritten, and it wasn't changed. What changed is people who historically had not qualified for Medicaid now could, and the federal government would pay 100% of their cost. Well, you think about that, and sometimes there's waiting lists to get on a state Medicaid, especially for kids and disabled kids, and this can be a problem. But wait a minute, you're telling those folks that they still got to wait in line, but these new folks that get 100%. And so the state's going to want to cover those because they get big federal bucks for covering those. Rick Perry was worried. I think I'm saying this correctly. I don't want to speak for him, but he was worried that this federal match would not continue in perpetuity. That is, states would obligate themselves to cover these new populations. And in Medicaid, you also have something that's called the maintenance of effort. Once you start, you can't stop. So it's sort of a one-way street. You get someone on Medicaid, and the state is then obligated to continue regardless of what the match from the federal government is. And this is a thing that concerned a lot of states, Texas, Georgia, I think Oklahoma, but they may have ultimately moved on that. But it's a real risk for a state to take that on. And in fact, it has come down. It came down from 100% to 90%. It's always looked at when you hear people talk about pay-fors or offsets. It's one of the things, we're really doing this wrong. If you're looking at a safety net program, you shouldn't be covering the people who could go out and get work and get employer-sponsored insurance. You shouldn't cover them at a higher federal match rate than people who are truly needy and deserving of the program. So there's always been that mismatch. I don't know why the wizards that created Obamacare. Now think about it for a minute. If they had just flipped it on its head and said, look, we're going to cover blind, aged, disabled, pregnant women under 200% of federal poverty level, we're going to cover them on Medicaid at 100% state match, and then these new populations will come in at the old FMAP rate. There might have made some sense to let's not disadvantage our legacy populations who are supposed to be covered by this safety net. Let's not disadvantage them vis-a-vis this younger and healthier population that is now being moved into Medicaid and being covered. I had wondered, and you couldn't get anybody to talk to you back in 2009 or 2010 on the Democrat side, but why not identify those populations and then perhaps allow them to buy into the system that the state uses to cover its state employees? Why does it always have to be some cradle-to-grave establishment that the federal government is going to run? And again, people wouldn't even talk to you about that. Now, too cute by half in the passage of Obamacare. Of course, they were sued several times, and the individual mandate drove people crazy. Everyone's forgotten about that now because it was relaxed in the 2017 Tax Cut and Jobs Act. But people were required to buy these very high cost, very high premium health policies that had high deductibles. And if they didn't buy it, they were going to get a fine.
A tax.
A tax on the individual mandate.
That's right.
And so I thought,
which of course was even though it was compelled for people to buy the insurance, that the tax was ruled illegal by the Supreme Court. It was ruled, the individual mandate was ruled legal.
Because it was a tax.
Because it was a tax.
Even though they denied it was a tax for years and years.
That's a rose is a rose, right, by any other name. But then Congress said, well, the penalty for not is $0. So even though you're still being penalized, the penalty is $0.
You still got to file the paperwork. And I actually worried during the Biden administration that they might reinflate that balloon. They didn't, obviously, because they saw that there'd be a political downside to doing that. It was very, that was the most distasteful. There's a lot of distasteful language in the Affordable Care Act, but the most distasteful was that in a free society, you can be compelled to buy a product that is then regulated under the Interstate Commerce Clause of the, it is just it was so wrong on so many levels. So several states brought suit over that. Also, there was suit brought about the expansion of Medicaid because states, the federal government and the state government share the responsibility for taking care of the safety net population. You cannot coerce a state by threatening to withdraw what has already been agreed upon.
Right.
And so that the Supreme Court ruled that the expansion of Medicaid was not automatic, as the people who wrote the Affordable Care Act believed it would be. It would not be automatic according to the Supreme Court, and every state had to either opt in or opt out. They could not be coerced.
And the coercion being that if you didn't expand Medicaid, they would take away some of the Medicaid funding from the state when that was a completely independent, which could have never been conceived that would be negotiated after it had already been negotiated. Now you're going with different legislation saying, well, now we're going to do this new contract over here that if you don't sign this contract, we're now going to take this away in a different contract, for lack of a better term.
So the Supreme Court said it was coercive and it was not allowed on that basis. That's what gave us the situation where you have some states that participate and some that don't. Now, there's been a lot of pressure put on Texas to try to get them, and Florida and Georgia, to try to get them to bring this expansion of Medicaid to their states. And you look at it on the face of it and say, well, it's federal money. Why not do it? And the problem is, of course, the $38 trillion in debt that the federal government has and the risk of fiscal collapse if that debt to GDP ratio stays unbalanced for too many years. I was on the budget committee for several years, and it's a real problem that you have to borrow more money to pay interest on the national debt than you pay to defend the nation, the Department of Defense or Department of War. Now, its appropriation is smaller than the amount of mandatory funding that has to go out to pay interest on the national debt. That's a scary situation, and that's only getting worse. Every dollar that's spent is a dollar that's borrowed. And so you have to, if you're really going to truly account for what a program costs, you've got to add that 50% carrying cost to it.
You've got to add that, right? It's when you go borrow money to buy a car, right, or a house, that 4, 8, 10, 12% interest has to be factored into your budget.
It has to be amortized. That's right.
And just like we see as interest rates go up, then house purchases go down and car purchases go down. And so we as individual citizens, we manage that where Congress maybe doesn't. But also I think about, there was a time when I got out of college and I was dirt poor and I was using one credit card to pay another credit card. It's the exact same situation. Right. But I had no choice.
This is not a financial advice show, by the way. Don't do that.
No, this is a survival show, right? So that's what I had to do to get through until I could, make some money and pay everything off. But my number one focus was paying that off, right? Which is not the focus that's today. But then it also matters who owns that debt.
Yes.
Right. And so who owns that? The majority of U.S. bonds, who owns the majority of that debt?
Well, you'll hear that China owns, and they do own a good portion of that. I went one time down to the Bureau of Public Debt and watched.
There's a Bureau of Public Debt.
Yes, there is.
So we pay people to be a Bureau of Public Debt. I gotcha.
And they sell U.S. Treasuries on not the open market. There's an
exchange for it.
Exchange for it. To be on, you've got to. There's no foreign governments that are actually part of that. They're big investment banks.
Sure.
This was right after the 2008 meltdown, and I was trying to learn more about why in the world are we in the straits that we're in. But it was an educational day to go down to the Bureau of Public Debt and watch the when the auction started on the U.S. debt, and it starts off very, very slow, and nobody wants to bid, and then suddenly it all happens, and all of the bond issues are subscribed to, and it's over within about 15 minutes, and then those individual banks will then go on and resell that to perhaps a sovereign wealth fund of a foreign country. So it's yes, there is the Chinese holders of U.S. debt. It's not just sold to the Chinese. It is sold to investment banks who then in turn turn around and sell it to foreign investors. But it was startling to watch that.
Mm-hmm.
And, it begs the question: what would happen if you go in there someday and anybody want to buy this stuff
Mm-hmm.
because it's so risky? These are junk bonds.
Mm-hmm.
we don't want them. What happens then? Well, then the Fed has to buy them all,
Sure.
and because they don't want the sale to not be culminated. But then you're obviously in a spiral that is going to be very injurious if it goes on very long. So it was
be like a run on the bank.
Yeah, be like a run on the bank, and Mr. Potter would win. And
Mr. Potter would win. Good old Mr. Potter. That's an old drawback. Y'all can look up who Mr. Potter is.
It's a Wonderful Life. Great movie. Watch it at Christmas.
Excellent. Yes.
So that was a real education for me. You people talk esoterically about the national debt, and then to see it laid out there, and other people in the room, I guess they knew that after this goes on for a few minutes, people will start to jump in and start to buy it. But it was kind of a tense moment there where they ain't selling.
Mm-hmm.
Nobody's buying, and it is over pretty quick. And it only happens a couple of times a month. I guess the Fed deems when they've got an issue to sell, but it's and this is why I think President Trump is so correct when he's inveighed against the chairman of the Fed. You've got to lower interest rates,
Mm-hmm.
and they do.
Mm-hmm.
In 2001 and 2002, I was completely the opposite camp. Why in the world, with inflation going up, are you not responding with by raising the interest rates? And
Mm-hmm.
the reason they didn't want to do that is they didn't want politically to push the country into a recession because that would reflect badly on President Biden. But they're not supposed to behave that way.
Mm-hmm.
They're supposed to look at They've got two jobs. One is inflation and one is employment. And then when they see inflation going up to 8 to 9%, you've got to begin to corral that. And so bringing the interest rate up in perhaps the latter part of 2001 and certainly the early part of 2002, of course they should have done that. But for Jerome Powell to say, well, we're just not worried,
Yeah.
we think it's transitory, for what's her name, who was Secretary of Treasury at the time, to say, oh, this is not a real phenomenon. Oh, these people should have lost their jobs immediately over that. And then Chairman Powell, Trump's right in calling him too late because he was too late at raising interest rates, and now he's too late in lowering them. And it makes a difference. The Congressional Budget Office then has to factor in the cost of interest on the national debt. This is a mandatory expense after all. So when they do their budget baseline, their budget projections, if the rate stays where it is now, it actually adds a line to the federal budget, or it adds a greater number to that line in the federal budget than perhaps is really justified because of the market conditions of the time. So there's no question they should lower those rates. If they lowered those rates, then the price tag for the one big beautiful bill actually comes down considerably because you don't have that carrying charge on the borrowed money, which right now you do because way too much money was borrowed in the Biden administration, and so that debt needs to be refinanced at a lower interest rate. Bill Clinton did that in his either his first or second term. I don't remember which it was. In fact, there was a lot of criticism that he's refinancing this long-term debt with short-term instruments that are lower interest rate, but they're shorter term, and then you're going to have to pay the piper at some point down the road. And then it didn't happen, and it kind of opened the door to a long-term expansion of the American economy. Well, that same thing, Trump needs to have that same tool at his disposal today. So when he argues that Chairman Powell needs to reduce the interest rate, he's absolutely correct, and that does need to happen. I guess it is now slowly happening, but it's been painful to watch. It was painful to watch when it should have gone up and it didn't, and it's painful to watch now that it should come down and it isn't.
It's where, as you were speaking through that, where I think, again, private citizens, when I think through that, it's more the perception that the executive branch is influencing the Fed when the Fed should be independent and all those sorts of things. But regardless, what I appreciate, I can argue for and against, but what I appreciate that there aren't term limits is that if we don't learn from the past, meaning if you haven't been in Congress long enough, you may not appreciate some of the things that happened in the past and you're doomed to repeat them. And so I appreciate that you're around long enough to go, I remember with Clinton, this is what happened and this is what we need to do.
To be fair, I wasn't there with Clinton.
I understand, but you've been around long enough to see things come and go and come and go. It's like watching fashion, right? Yeah. Bell bottoms coming back into fashion, right?
I don't think that's going to happen.
You know what I mean. And so I appreciate that you have a long enough time period, that you've spoken with enough people, that you really have an educated view of what has happened in the past and what needs to happen in the future, as opposed to when you were a freshman congressman, you didn't have some of those perspectives, and you weren't, I would assume, not able to make as educated decisions as you could now based off of your experience.
No, I've always been
that educated.
An uncanny ability to see what's intuitively obvious to the casual observer.
Right. So back to healthcare, right, which is just such a big issue in this country. So I just think about the questions I get from my clients every day, right? So I represent clients that are trying to bring medical devices into the U.S. healthcare system, whether it comes from the U.S. or outside the U.S. And there is a lot to do of getting through FDA and Medicare and all the private payers and putting everything together, let alone your clinical evidence and financial and commercial strategies. It is very, very complex. And when we look at all of the things going on in Congress, let's go all the way forward right now. There are some things I want to get to that are a little more historical and hysterical, but right now there's the WISER model that was released from the Center of Medicare and Medicaid Innovation. And what they've basically done is said, hey, we've identified therapies that we think might have a high level of fraud, waste, and abuse, and we are going to require, for the next 6 years, prior authorization for those therapies in a certain number of states. And so it's a pilot program. And what that means to me when I see that is this is Medicare's kind of sticking their toe into prior authorization, like utilization review, which is one of the biggest issues we see with private payers at the moment.
It's worse than that.
Well, and just for people who are listening, right? So when anybody who's needed a surgery, you'll hear their doctor tell you, I've got to get your insurance to authorize this. And if the insurance doesn't authorize it, you have a really big problem, right? And the amount of work to try to get that approved is exponential, right? And one of the value propositions of traditional Medicare has always been, since the 60s when it was implemented, is we will not do prior authorization and we'll pay you quickly, right? Which is part of the whole thing. That was to get physicians into the Medicare program. Now you see the writing on the wall. It's very obvious to me that that's what they're doing. And purely, I'll say this, and anybody that's listening, my frustration acutely is they've named therapies in general, right, that they are going to implement prior authorization starting January 1 of 2026, which is less than 3 months away, but they have not yet identified the actual CPT codes. So all of us who are launching therapies in this country, we're less than 90 days away, and we don't know if Medicare is going to require prior authorization in those states for those particular therapies on a CPT code basis, which I can tell you, as we try to raise money in this country, that's the first thing investors are saying. Well, is that going to require prior authorization by Medicare? And let me tell you, Medicare is the 800-pound gorilla. If you've got a problem with Medicare, you got a problem, right? I equate this to the IRS. If you have a tax problem with the IRS, you got a problem, right?
Well, and if I understand what they've proposed in the WISER model, it's not just a prior authorization model. It's an after-the-fact model. That is, they will look at what they deem as low-value care and come after the fact and say, we've identified these procedures or this care that you've rendered that we don't think should have been given in the first place, and we're gonna take the money back.
One of the things that it says in there is if you choose not to get your procedure prior authorized, then you are subject to post-payment review.
Post-payment review, yes.
Right, and it really becomes post-procedure review before they pay you, right? And so now you're in a worse situation because now the patient's already got it. You've expended all of this money and time to provide the patient a therapy that all the other states can do, not a problem. And there was no public comment to any of this. It just happened.
Yeah, this is one of the there's two things we need to talk about here. We need to talk about Wiser itself, but we also need to talk about this so-called innovation center that was part of Obamacare, CMMI.
So just to be clear, so CMMI was created as a function through Obamacare.
It's a budget gimmick. It was a budget gimmick. I don't know. People have such short memories. President Obama would stand up there in front of Congress and say, this health care bill is not going to add $1 to the deficit. In fact, it's going to return $142 billion to the federal treasury because we're going to save so much money. Okay, newsflash, it didn't work. They didn't save any money. It's cost a lot more money than anyone ever imagined. Witness the advanced premium tax credit that got plussed up a bunch in the Biden administration, and now everyone's raising Billy Cane because that plus up is going to expire at the end of this year. Oh, my God. But everybody knew that it was never going to work with the dollars that they had identified. It wasn't going to work in the first place. But one of the budget tricks they used to keep it from costing so much was, we're really going to move to a value-based care proposition. So the Center for Medicare and Medicaid Innovation, CMMI, as it's described, now has enormous power by describing these models, which you've just outlined, and there is no legislative input. It's not that Congress says, well, we think we need to look at this, and we as members of Congress have determined that this needs to happen. Not that members of Congress are so damn smart, but they're at least sensitive to their constituents who say, oh, we didn't like what you did there, and we're not going to vote for you again.
Right.
But CMMI is completely removed from that equation. You talk about something that is monarchical from top to bottom, and that is CMMI. And here's the dirty little secret about CMMI. All the talk that's going on right now on the budget, okay, we want a continuing resolution to last November 21st because we are going to get all of our appropriations bills written, and the Appropriations Committee is working on writing those bills. They knew that September 30th was coming up. It happens the same time every year. How could you miss the date yet again, Appropriations Committee? But I won't get into that. When they were having one of their markups on the Labor, Health, and Human Services bill, Lois Frankel, a Democrat from Florida, introduced an amendment. It's called a limitation amendment that said no money in this appropriation shall be spent for CMMI to do Wiser. Well, okay, I've done limitation amendments myself, and it's an important tool to have. But guess what? It doesn't work in this instance. And the reason it doesn't work is because CMMI is pre-funded. That is, the money is already in the bank.
Already allocated
for CMMI for the next 10 years. This is the way Obamacare was written because the Democratic chair of the Appropriations Committee, very smug about this when she came into Rules Committee several years ago, Nita Lowey from New York. And I'm like, well, Republicans will stop this funding dead in its tracks when we're doing appropriations. And she said, no, you won't, because we pre-funded it.
So it's moot. I mean, the whole argument right now is moot.
Yes, they have the money to do whatever the hell they want. Now, I would argue, if I were still in Congress, I would argue that, and I have argued this in the past, you need to do away with CMMI.
Well, let me ask you, can't the new Secretary of Health and Human Services disband CMMI if he wanted to?
Why would he want to? He has enormous power and it's already funded. Why would he want to? He can go back and tell doctors, no, you can't do that. If you do that, we're going to take money out of your next check because we didn't think you ought to have done that.
Okay, so forget so what I hear you saying then is he'll want CMMI, maybe, but he could stop Wiser.
Could, but why would they? The reason Wiser is there is they are going to use AI algorithms to sift through all of these claims that are filed and pull back dollars that they deem were dollars that were spent on low-value care. Not that your doctor deemed was low-value care.
Right.
Your doctor has recommended this care. Your doctor who went to medical school and residency and postgraduate training has recommended this care or delivered this care. But now a bureaucrat at a federal agency, I don't care whether it's a Republican or Democrat in charge of the White House, but a bureaucrat at the agency is going to say, we're going to apply now AI tools to tell us that vast numbers of these dollars were inappropriately spent. So the next check that goes out to the providers is reduced by this amount. It is a terrible system and one which is doomed to fail. I don't know if there's going to be another reconciliation bill. You know, reconciliation is where you do things because the Senate requires 60 votes to get. That's why we're arguing about the appropriation stuff now, because they can't get to 60, even though they've got a majority of senators voting for this funding.
Right.
But a reconciliation bill is a way to get around the 60 vote threshold that is needed for a normal appropriations bill. So if they do another reconciliation bill that only requires 51 votes in the Senate, I would recommend you got to get rid of CMMI. Look, I get criticized a lot. You voted to repeal Obamacare 78 times. Well, yeah, I have. And some Democrats voted with me on some of this. What about the medical device tax? I mean, it was kind of a little bit of a repeal of Obamacare.
That's right.
That was very necessary for the medical device industry to be able to move forward and bring us all of these new innovations.
It was an excise tax.
It was an excise tax, a
yeah.
10% excise tax after the fact that well, we can get into all the reasons why it was done, but it was to go after the medical imaging people, but they didn't want to go after the medical imaging people. They just levied a tax on all medical devices, from Band-Aids to electron microscopes and whatever else.
Pacemakers and everything.
Pacemakers.
Yeah, exactly.
But CMMI needs to be repealed because of the unbalanced power that it has. And it takes, if I were a legislator, I would not want CMMI to continue to be there. Now, when I met with the transition team prior to the 2016 election, nobody knew Trump was going to be elected, but I met with his transition team, and I was like, one of the things you guys ought to do is get rid of CMMI. I've tried to while Biden was president, but he's never going to sign that bill. So you all need, and it was like, well, but you know, there's a lot of power there. We might be able to use this as a force for good. Okay. I bought it. Maybe it could be used for a force for good, but I watched for the first 4 years of the first Trump administration, and never once was it used as a force for good. Now we're seeing the very worst parts in the second Trump administration. The person who's in charge of CMMI has put forward this wiser model. While I appreciate that they want to save money in Medicare, they want to do this ex post facto ruling on care that's already been administered in traditional Medicare. We're not talking about Medicare Advantage,
right?
But in traditional Medicare, which most people think is now protected from prior authorization. But as you put it, if you don't go through a prior authorization process, we will perhaps come back and claw back the money that we don't think you should have spent.
But they've already had, I mean, so Medicare has always had the power that they could come back and audit and recoup monies through RAC audits, right?
Yes.
Recovery audit contractors. So that power has kind of been there. It wasn't pre-payment review. There was post-payment review. But nonetheless, where goes to my mind is speak softly, carry a big stick. Just like the IRS, right? We're going to trust you until you give us a reason not to trust you. Same thing here. And I've been doing this for 25 years, launching medical devices, worked with doctors all over the country. And there are good actors and bad actors, just like we see in everything. And using a legal term, I get frustrated when I'm negotiating on a side and we don't have clean hands, right? That really weakens your argument. And so I think there's, you know, dirty hands on every single side. Nobody's clean. We try to be as clean as possible, but I get frustrated when something like the wiser model comes in. And think of my perspective, right? I'm private. I have my own company. I work with medical device companies. We're trying to raise money from private investors and all these folks. And the one thing that we need more than anything is predictability. And when the wiser model now being implemented, there was no opportunity for the public to comment.
No.
What I have really appreciated, anybody that's worked with me knows this, I appreciate the federal government in their transparency, 100%. So Medicare, every summer, they issue their proposed rules for outpatient and physician and surgery centers, all come out around 4th of July. And then you have the opportunity to comment on anything you want, if you want to read all 1,000 pages of it. But you have that opportunity, and they actually do listen. I have to say, we've written comments, and when the final rule comes out around Halloween, really the first week in November, for what's going to happen that coming January, what I really appreciate about HHS or CMS in that situation is they actually respond to those comments and say, hey, we either agree or disagree with you, and here's why. Like, I love that process. It gives us predictability. We're part of that process. We can influence the process. I love that. Same thing with inpatient. That's on the fiscal, but nonetheless, there's that opportunity. Same thing with CPT, right? Through the AMA, all of that is public. Anybody can see it. Anybody can participate, and you have the opportunity to be heard. When you look at CMMI, it just got implemented, meaning this year, so earlier this year. It goes into effect less than 90 days from now, and we still don't know exactly what's going to be impacted. And I was with a client, we were doing fundraising, trying to raise hundreds of millions of dollars. And that question came up: what is the future of this therapy under the WISER model? And when you're trying to raise that kind of money and that question comes up and we have to say, I don't know. Do you think an investor is going to say, well, here's $100 million, right? It just doesn't happen. And so what does happen is, well, okay, we'll give you the 100 million, but not for 49% of your company, for 51% of your company, which we all know has massive impacts, right? And so it's like, golly, government, that is not what the purpose of this is, right? Everything is supposed to be transparent. And that part I'm really frustrated with from a CMMI perspective. Forget that it was pre-funded. Forget that it was out of Obamacare. Forget all of that stuff. It affects me, my clients, and launching new therapies in this country because there is zero input we can have to that process.
Correct. And in a normal situation, you could involve your senator or your member of Congress and say, help me here. This is going to kill innovation in this country. This is going to kill entrepreneurship in this country. And your member of Congress or your senator would respond, and one of the responses might be a limitation amendment in a funding bill. But it turns out that doesn't touch the problem that you've got, because it was written in a way in the original law in 2010 that Congress can't impact it on purpose, because they wanted to remove those pesky Republicans from coming in and trying to monkey with things.
Yeah.
But that really has no place in our system. And I don't want to sound like a whiny legislator, but this takes the legislative branch out of the equation. And that's not right, because we're the people's closest contact with the federal government.
Well, and you're our advocates.
Yes.
And if you have lost your power, think about how the public feels, right? And most people in the public have no clue about the WISER model. I get that. But anybody in the med device industry knows it extremely well, of what's happening and how that affects the future of their business, quite honestly.
Well, and of course, you and your group have done some great work on the prior authorization side of things. I was interested to note, I was reading one of the little online newsletters that I get every morning. I can't help myself. I got to look at that stuff.
Of course.
And they always have, brought to you by. So today's brought to you by was United Healthcare, which recommended passage of the Seniors Timely Access to Care Act, which is the prior authorization or the bill that is proposed to kind of put some guardrails around prior authorization. It was just interesting to see United Healthcare, which may be one of the worst abusers of the prior auth process, being a United Medicare Advantage program and having had several things denied over the past 6 months. I just thought it was somewhat ironic that they're advertising for the passage of the Seniors Timely Access to Care Act, which is great. I think it's a good bill. You've been behind it. I've been behind it. I've voted for it in the past. It's always gotten gummed up in the Senate somehow, but it should pass this year, and it would be a good thing to have that, because of what you just identified, having some certainty around the parameters. What are the rules of the road that people are going to be having to follow going forward? But there's nothing more frustrating for me than getting a call from some call center in the Philippines that said, we've looked at your labs and you no longer require this medicine that's very expensive. And I'm like, holy hell. who is this care team that you keep talking about? Is there a doctor? And they said, well, we've got doctors. And I said, well, I hope he has a license to practice in the state of Texas, because if he doesn't, he's practicing without a license, and I'm calling the Texas Medical Board to go after him. And then, of course, they always approve it. But most patients don't have the suckle to say, do that. This is how you counteract a prior authorization denial. You do it, but probably better than anyone else on the planet. I do it because I'm a frustrated consumer, probably the only member of Congress who was on Medicare Advantage for a number of reasons. But, that's why it's important for us to be, as members of Congress, you create a new program, Medicare Advantage, you ought to have to take Medicare Advantage when you get to Medicare age. This should be a requirement. And everyone should know the program that you're building today, in this case in 2003, is the program that you're going to be living on in 2025. This should be in the back of the representative's mind. And again, that's how you get a representative government that is sensitive to the needs of constituents. Otherwise, if we're just governed by bureaucrats and technocrats, oh yeah, they can think of, there's lots of social tinkerers out there who want to tinker with the practice of medicine, but they've never spent a minute in an exam room or an operating room or delivery room. They have no idea how this stuff is supposed to work.
So, Michael, I appreciate your passion on this. And there's a part of me, a little devious part of me that's like, yes, you had to live this difficult part since you retired, because when you're in Congress, everything's taken care of. Now that you're retired, you chose Medicare Advantage. Now you're subject to prior authorization. You've been denied.
Let me correct you on that. I was on Medicare Advantage as a member of Congress. I turned 65.
Oh, when you turned 65, okay.
In whatever the hell that was, 2015. So they kicked. I actually was on Obamacare.
Is that right?
Because I thought, that was the way the law was written, that members of Congress should be on it.
Mm-hmm.
But then they were worried about a brain drain in the 2016 elections, and that everyone would leave Congress and not be, or I guess on the 2014 elections. So Harry Reid and Barack Obama and John Boehner, who was the Speaker of the House at the time, all got together and put together this package for members of Congress. And if you would go on the gold plan in the DC exchange, that you would be subsidized, I think it was $550, because, yes, we had employer-sponsored health insurance up to that time. So now we're having to move to Obamacare, but there still will be a subsidy. But no other person in the United States of America got a tax-free subsidy walked into the exchange for them. Only U.S. House members and senators and their staff. So I said, well, that's not right. We can't do that. We're going to get sued. We're going to get spanked. People will rise up as one and say, you carved out a special deal for yourself. This would be like taking a private jet. Well, turns out nobody did push back. But I took myself out of the federal employee health benefits program at that point and said, no, I'll go on to the marketplace. The most miserable experience I've ever had in my life. But again, we're supposed to have to go through what our constituents are going through.
Sure.
So I went to healthcare.gov, filled out all the forms, answered all the questions from all the probing little nincompoops who were calling me, asking me, and you don't even know. You get a call in the middle of the afternoon from someone who identifies themselves as from some place that is going to provide you insurance, and they start asking you all of these questions. And you provide them answers, but you don't really know who they are. I mean, have we not all learned our lesson? Be careful about clicking on that.
So you're telling me with all the billions you made with your stock trades, you didn't just buy your own insurance? You
should have bought my own insurance company.
Yeah.
But no, as a member of Congress, you were supposed to be on Obamacare. Most members of Congress did not do that the way the average citizen does. That is, go on to healthcare.gov. You'll still hear them complain about it because the premiums have gotten very high, and even the subsidized premium in the gold plan and the DC exchange is extremely expensive. I didn't want to do that for a number of reasons. One of them is my doctors are in Texas, not in DC, so I don't want to have to disrupt everything as far as my healthcare and move it all to DC. But it seemed wrong. It felt wrong. Like you said, you can't have dirty hands when you're sitting at the table,
right,
and dealing cards. So it didn't feel right. The Grassley Amendment was passed as part of getting Obamacare passed. This required every member of Congress to be in Obamacare, but they found a workaround to find a special place in Obamacare that was still subsidized by the federal government. And I said, I can't do that. So I vacated my tenure in the Federal Employee Health Benefits Plan, which means that it was not available for me when I then got to Medicare age. Most members of Congress, when they do retire, they are on an FEHBP plan that has a wraparound with Medicare. But I didn't do that. I just had to sign up for Medicare Advantage when I got to Medicare age, because that wraparound plan was not available to me, no longer being in the Federal Employee Health Benefits Plan.
So you were there in Congress when Medicare Advantage was created, right? And so Part C, and I want to get to how it's actually run today as opposed to the intent. I mean, the intent I think was admirable. To be able to offer a kind of holistic solution. So Medicare originally started just as inpatient, then they added outpatient and physician, and then drug coverage. They had all those things, but there's no dentistry, there's no vision, there's none of those things, or wellness programs or anything like that. And so this was to enable packaging all of that so that a person who's Medicare eligible can get Medicare Advantage and get a whole suite of benefits from one provider and make it simple. And I'm overgeneralizing, but that's basically what it was. The key then, though, the power that was given then Medicare Advantage plans was the power of prior authorization. And there were other things, but that really, in my line of business and all my clients, that's a big issue. And so to give you a sense, so Medicare Advantage is supposed to follow all of the Medicare rules, right?
Yes.
And that's a struggle right now, because when you look at new and innovative therapies, there may not be a Medicare policy, a national coverage determination, local coverage determination. And if there isn't one, then the Medicare Advantage plans can kind of do what they want.
Until they're caught.
Until they're caught. And so what we run into, so we have a particular situation where, in my company, we launch only new and innovative therapies, right? And they have the biggest challenges when it comes to getting adopted by Medicare and insurance carriers, but they're the ones that are representing innovation in this country. So I'm proud to represent them, though there's a lot going against them. And one of them being Medicare Advantage. Now that over half of Medicare eligible population chooses Medicare Advantage, this prior authorization, out of our data, we see 30% of patients who have Medicare Advantage getting automatically denied. Denied. And there's just somebody hitting a deny button. And we all know from the news, there's that bulk deny button, right? A physician's supposed to review every patient prior authorization. But there is that little checkbox that says select all, deny. And they all come through. We see it every day. So 30% of the patients that we see with Medicare Advantage get denied. 100% Medicare goes straight through there. Well, there's actually no question about it. What happens then is we appeal those denials internally to the insurance company. Then it goes externally, and then we take them to ALJ court. So actually do appreciate what Congress did was empower ALJ court over Medicare Advantage. Administrative law judge. That is so valuable that there's a place for patients to be heard. And we've leveraged that many, many times. When we go through that entire process, we get the approval rate from Medicare Advantage over 90%. And so when I think about that, you go, okay, well, there's that 20% delta, that 70 to 90%, that 20%, that if those patients didn't have advocates like us fighting every single day, they would never get access to this therapy that they would have if they stayed in Medicare. So when people come to me and they're like, Chris, should I do Medicare or Medicare Advantage? I'm like, Medicare? Are you kidding me? Absolutely, because this is a challenge. You know it by choosing Medicare Advantage. This was never the intent. It was actually to provide value to Medicare patients.
Right.
And now it's being used as a weapon, as evidenced by the fact that Aetna no longer has commercial plans. They only have Medicare Advantage plans. Well, why would you do that? Well, because
that's where the money is.
That's where the money is.
That's why you rob a bank, right?
So when you start subsidizing private industry through the federal government program, all you have to do is follow the money and look at the behavior of carriers and what they're doing. Do you think they're signing up to do more exchange programs? No, they're actually opting out of the exchanges, and they're going to Medicare Advantage because of the way it's funded, right? And then they're I would say, overdiagnosing patients so they get comorbidities and get higher monthly payments. And then they stop patients from getting access to therapy so that they can pad their bottom line. Just look at the profits that they're making is ungodly. Right. And we're on the phone. I've got a team of case managers. We're on the phone every day with patients, with the physicians, with the medical device companies. And the anger and frustration that we hear every day is overwhelming to the point where you want to give up some days. And that's exactly what it seems like the entire system's set up to do, is to give up.
Yeah, it's an obstacle. Access to a waiting list is not access to care. Access to a queue is not access to care. So, I mean, there are ways around this. And in the Seniors Timely Access to Care Act that you worked on, I know, I voted for it in the past. It does need to get through this Congress, but it's only going to fix part of the problem.
And let me make that pitch, right? So I don't know who all is going to watch this, but and this is Congressman Joyce was part of co-sponsoring that and authoring that, which is the Senior Timely Access to Care Act, which provides for more accountability on Medicare Advantage plans around prior authorization. So that part is so important, and we provided language for that if Medicare Advantage isn't held, we'd like complete changes, but we know that that ocean's not going to get boiled. So let's just make some coffee at the moment. Let's just have some metrics that show their denial rates with regard to therapies and how patients are being denied access. At least expose it. I mean, that's what the federal government's supposed to do, right?
Yes, that's what Congress is supposed to do.
To share all of that information.
Our
and when
oversight function that's what we're supposed to do.
That's exactly right. And I know this takes forever, but if we don't fight for patients to do this, to get access to it, or to see this, it's never going to end. And so it's really frustrating, and I'll end up going way off track on this. But I need people to support their congressmen and women in moving Senior Timely Access to Care Act, which is bipartisan, by the way, to hold Medicare Advantage plans more accountable to their denial rates and prior authorizations. Because again, if you chose traditional Medicare, you would have gotten access to these therapies. No questions asked. It's not a problem.
But you also need to buy a supplement plan because it only covers 80% of your expenses.
Of course, supplement or secondary, yeah, exactly.
And you need to buy a separate drug policy because it does not cover Part D drugs, which Medicare Advantage does.
So that was part of the benefit of Medicare Advantage, yes, and why you voted for Medicare Advantage.
Sure, because of the holistic approach. And there's another part of it. Sometimes they do create such narrow networks that you wonder, what the heck am I doing in here? Mm-hmm. But
fair, yeah.
They are supposed to have a provider for you. You sign up with their plan. One of the problems in Medicare, as you know, the cuts to reimbursement to physicians that have happened year in and year out for years and years mean that some doctors will just not take a new Medicare patient. And so if you're even, on traditional Medicare, if you pick up the phone and call a medical office and they say, who's your insurance? And you say Medicare, I'm sorry, we're not taking any more Medicare patients. That happens all the time. So one of the advantages to Medicare
I did that, by the way. I called a provider just to see if I get an appointment. I was just testing your theory. We had talked about this a long time ago. So I called and said, I'd be a new patient. What insurance do you have? I said Medicare. And they said, we're not taking new Medicare. Call back later. I was hoping to get somebody else on the phone, which I did. And I said, I have Blue Cross. And they said, oh, yeah, we can see you next week. And I'm like, there it is. There it is. I mean, just try it. And it happens every single time.
So you didn't believe me?
You had Medicaid.
You didn't believe me? And
trust but verify, Michael. Trust but verify. But imagine even for Medicaid. Right? I mean, that would be 10 times worse.
10 times worse because the reimbursement rates for Medicaid are set at the state level. And every time the state gets into a budget crunch, they cut Medicaid reimbursements. It's one of the first things that happens in Texas every 2 years when a budget's constructed. They ought to protect that a little bit better, but they don't. And this is why I could never be upset with Governor Perry when he wouldn't expand Medicaid, because no doctor takes it willingly anyway. You've got to be literally on emergency call, and now you get assigned a Medicaid patient. I mean, that's literally how it happens. Mm-hmm. But anyway, back to your point, one of the advantages for Medicare Advantage is that there is, at least when you sign up, they say, here's our provider network, and they make that, it's publicly available. Now, it may change during the year, and they tell you that. But and if it changes too much, you can there's a kind of a backdoor where you can go through a couple of months into your Medicare Advantage program in early January and early February and make a change if you find that it's necessary. But that's the way it is supposed to work. So for me, when I made the decision, what am I going to do here? Well, wait a minute. I don't want to have to go out and buy a supplemental. I don't want to go out and have to buy a separate drug policy. These guys will do one-stop shopping, turnkey experience. Mm-hmm. Yes, they charge a premium that is in addition to Medicare. So, but it was reasonable. It was, and I knew I was getting Part D coverage as part of the deal.
Sure.
So it made sense. Not like any other consumer. I buy on price, right?
Sure.
And cost and complexity both figure into the equation. But here's a relatively straightforward way that I didn't want to make a mistake and forget to buy the Part B insurance or the Part D insurance, and then I'd be penalized for the rest of my life because I didn't get it in time because those rascally members of Congress they ding you if you don't buy Part D in within 60 days of your 65th birthday or something. So I was concerned that I wanted to be sure that I had the coverage and that I had ongoing coverage, but it also it gave me access to a provider that otherwise I didn't know that I would have the ability to get a doctor to take my Medicare. So that's a big selling point for Medicare Advantage. I have encountered more so in the past couple of years, just sort of the random call in the middle of the day. Oh, we'd like to audit your coverage for you. Well, wait a minute, and I never respond to those. But what they're doing is what you said. If we can add some other diagnostic codes to this joker, we actually get a bigger check from the government for providing their care.
That's right.
So if you're taking a Celebrex for arthritis, crippling arthritis, and they put that on your tab. So if there were a way to, for years before I was on Obamacare and everything else, I had a health savings account. I actually think and I realize it's not for everyone, but there are policy changes that can be made that make a health savings account more straightforward. And here's what I liked about a health savings account. I was able to contribute tax-free money or pre-tax dollars into this health savings account every year. If I didn't use them, they stayed in that account and they were available for me next year or the year after the year after. And that is Mitch Daniels, who was governor of Indiana, explained to me one time, something magic happens when people spend their own money for health care, even if it wasn't their money in the first place. So, in fact, if you did a Medicaid or Medicare health savings account where now the federal government is actually making a contribution on your behalf into your health savings account, but now it's your money that you control. You've got to only expend it for health expenditures, but it's going to be there for you when you need it. That actually can be a pretty powerful inducement for you only do things that are really necessary. When we all talk in lofty terms about value-based care, patients are pretty good determinants, and they tend to buy on price. They tend to be pretty savvy consumers.
When it's your dollars,
yes,
just like with my teenage kids, it's like,
with
buy
clothes
me
or
this
televisions.
$200 sweatshirt. And you're like, no, you buy it. Well, I don't want to spend $200 on a sweatshirt.
It ain't worth it.
Of course you don't. Neither do I. Right?
You're making the argument against congressional earmarks too, by the way.
Sure. Yeah. Right.
If the city wasn't going to spend money on it, why should the federal government?
Everything that we've talked about, it seems to me, I keep coming back to history. Right. It was never conceived that our federal government was going to be an insurance carrier. Right? It wasn't even conceived. I'm not saying that it should or shouldn't today. My point being, it was never designed that way. It was never conceived that way. And I appreciate, why the Social Security Act came into play and what happened in our country at that time and all of those factors that came to it. And then I also appreciate then that kind of manifested itself toward Medicare back in the 60s and Medicaid. And I get the progression, but it's kind of like, once you throw a rock into that still pond, those ripples go out in two dimensions, really more dimensions, because it goes out in time. So that ripple that started the Social Security Act in the 30s, post the Depression, those ripples are still hitting us today. And the federal government, the moment they step into something, there can't be an unstepping because you've already created that ripple. Yeah. And now you're managing the ripples. And we're here today, and the students would just ask, or they would say that healthcare in this country is so screwed up. And you're like, well, let's look at that original rock that was thrown in, right? And there were actually multiple rocks that were thrown into that still river. and where they're crossing over today went through time, and why we're trying to address all of that. You can't unthrow the rocks anymore. And so how do we manage the ripples? And there are so many that it's unfixable, so to speak, on a broad term. All we can do, as I imagine, is I'm going to ride this one little ripple wave and let's see if we can fix that one thing. But what are your perspectives on just from a national perspective where healthcare is going and where there would be an opportunity to course correct, maybe?
So to follow your analogy, pretty soon you'll end up with a pile of rocks instead of a pond, right?
Yeah, well, that's exactly right.
This is the old Margaret Thatcher. Pretty soon eventually you're going to run out of other people's money. And that has always been I heard driving in this morning, I heard Ayanna Pressley, who's a very liberal woman from Massachusetts, who's a representative up there, and the guy's running for mayor of New York, Mondami. And both of them had similar, where they're talking about this continuation of the enhanced subsidies for the Obamacare, the advanced premium tax credit in the Affordable Care Act that were enhanced under the Democrats in the reconciliation of the prior administration. But it was so expensive, they put an end date, and that end date is December 31st. So now people are starting to pull their hair. What are we going to do when that enhanced subsidy ends? Well, first off, it's only the enhanced subsidy that ends. It's the actual original subsidy that's in the Affordable Care Act is not going to end. So a family 400% of the federal poverty level is still going to get a subsidy to buy their insurance. The way that subsidy was set up originally in the Affordable Care Act wasn't really flexible. That is, once you got to 400, it was great to have the subsidy, but once you got to 400% of the federal poverty level, it just went away. I mean, it was like it fallen off a cliff.
It didn't gradually go down. It disappeared.
In the district that I represented, that's a teacher and a policeman with 2 kids. They earn over $96,000 a year, and now suddenly they are on the hook for that full $6,000 or $7,000 a month premium from Blue Cross Blue Shield that they can't pay, and they've got a $6,000 or $7,000 deductible, so they're functionally uninsured. I would hear from people all the time that would come into my office and say, "This Obamacare, you're forcing me to buy it because the individual mandate was still there, and I truly cannot afford it." So, should there have been a way, if that sudden drop off at a 400% of the federal poverty level, could that have been gradually between 400% and 600% of the federal poverty level? Could that have been gradually relaxed? And the answer is yes. And that, ultimately, that's probably the answer that people are going to arrive at after they get through fighting. It's not a good system. And okay, what I heard Mayor Mondami, or mayor-to-be, nominee for Mayor Mondami say, you've got to have the subsidy to lower the cost of health care. And I'm going, oh my God, my head exploded. The subsidy does not lower the cost. It may lower the bill to the person who's buying it, but it doesn't lower the cost. If anything, it enriches the insurance company and it drives the cost up because of the phenomenon known as silver loading that was built into Obamacare. Silver loading, the way the Obamacare is written, the way the subsidies are designed, is that there is it's that 400% of the federal poverty level subsidizes a silver plan for that person in the Affordable Care Act. So the insurance company looks at that and says, well, if we just raise the price of our silver plan, we're going to get a lot more cash.
Of course, yeah.
And so they do. And the person who's getting the subsidy says, well, I don't care. I got a subsidy. So, what me worry, it's free money, so I'll take it. And the subsidy and the cost goes up. Unless you're outside the subsidy window, in which case you're getting hammered every month. And those are the people that I would hear from. And the reason I was so passionate about doing something with Obamacare, because it wasn't helping the people that I represented, which was a teacher and a policeman with 2 kids. So, again, there are ways to, like you like to use the analogy of boiling that ocean, there are ways of making that cup of coffee and making it work for that segment or those segments of the population. It still doesn't undo the underlying economic disaster that Obamacare is, but at least we can stop damaging the people who are the end users of the product because they simply can't afford it anymore. But the notion that we're making healthcare more affordable by subsidizing insurance companies, shut up. That ain't the way the world works. And it's never worked in housing. It's never worked in education. Did you make college courses cost less by providing a student loan subsidy?
College education is the perfect example.
No,
Yeah.
you did not.
It's ungodly expensive.
Now, I know people who are on the other side will come back at me and say, well, but what about things like the DFW airport, where the federal government subsidized some aspects of that and the economy of the whole area has improved as a consequence? Yeah. But that's a one-time, big-time expense. We're not talking about something that's going to happen every month, month in and month out.
That was an acute situation, not a chronic condition, right? Yes, when subsidies go on for a very long time, it has a negative impact. But there can be some value in a very short, acute, limited, bounded project for sure.
Well, like you learned when you were just starting out, don't borrow money for operational expenses. Borrow money for capital expenses. Where if you're buying a new machine, when I was in practice, if I needed to buy a new sonogram machine, that's a capital expense. I'd go into debt for that and make the payments. But if I went into debt to pay my assistant, my secretary, and my scheduler, it wasn't long before I was going to be in deep trouble and in fact out of business. So that's I'm not Dave Ramsey, but that's you always want to stay solvent on the operational side. You can go into debt for capital improvement, but it's you're damaging yourself or you're kidding yourself if you think you're going to do that for operational expenses.
I appreciate that you're not in Congress at this very moment as you say that, because you're talking like a private citizen who has a private business and who has a family of you can only invest in certain things and you have to be solvent, right? And you can't carry all that debt. So I appreciate all of that. There's so many things we could still talk about. And so hopefully we can continue this conversation another time. But I appreciate the dedication you brought for healthcare in this country for the 22 years that you were there. You're still a very strong advocate for physicians and patients and providers, as what will seem indefinitely continue to advocate for appropriate healthcare in this country, which, because of where we come from, is where we are, and there are only opportunities to fix it, and it's going to cost even more money to fix. But nonetheless, I want to thank you so much for coming by and chatting with us.
Well, thanks for having me. It's been a good experience, and yes, we should continue the conversation on the other side.
Excellent. Thank you.
Thank you.
Appreciate you.